Great, thank you so much for inviting me to speak today. I must say I'm yet another imposter because much of this work actually is from data collected at state level, so it follows nicely from Felix's talk on behalf of Victor. It's a state level data set that the CEC has been acquiring over the last 3 or 4 years, and I've been able to delve into a little bit of it today, and well, I'll show you what we've come up with. So the talk is Do Mandatory Calling Criteria Work in New South Wales, but I'm going to dispute that title, you'll see why. But by way of background, some years ago we had a girl that had a golf ball hit her on the head. She was a teenager and she became progressively more unconscious and then comatose and slightly aggressive for a short while in the middle of that, and was over-sedated and died. And that happened in one of our big metro hospitals, and it shook everybody. It was one of the reasons why we had a big inquiry in Garling, undertook that, and partly as a consequence of that we came up with the idea that, well, we need to keep people safe in the hospitals, and so we've developed yellow and red zones, and we were very grateful to Surf Life Saving Australia that didn't mind us completely stealing their colours and ideas, and the concept of safety within margins. For us, margins of physiology, for them a safe area of the beach, and colour coding in the same way. So the whole idea of this program is to provide a safety net, as you'd know, for deteriorating patients in hospitals. Now the program's got 5 elements, and the title says I'm going to talk about one element, which is the SPOC chart, or the calling criteria. And I will talk about that, but I'm not going to just talk about that because it wouldn't make any sense just to limit our conversation to such. So I want to start with that, though. I'll talk about the standard calling criteria, and also what are the behaviours attached to being yellow, being red. In fact, there's a blue zone as well, which, you know, the C's blue, so put that in. What do we do if you're in those areas of the chart? Our charts are standard charts for different age groups. They were developed by a panel of experts, which means they're probably well off the mark, and could have been randomly done by toddlers, but they weren't. They are track and trigger, so we follow observations. We only need one observation in the red zone, single observation in red, then you're off. You get a MET call. If you have 3 yellows, you get a MET call. The MET call happens as soon as possible by the MET team. People in the yellow zone, that's at the discretion of the local staff, particularly the senior nursing on the floor. They could request a medical review within 30 minutes and often do, but they don't have to. There's some discretion around that. It's a pretty sensitive chart. It triggers quite a bit. There's 5 of them initially, and the youngest, just worth pointing out that even working out how you band the ages was problematic, and we weren't quite sure how to do it. And our first go, we had anyone that wasn't a neonate but that was up to 12 months old on one chart, and that didn't work. And then we later changed that so that we had under 3 months and then 3 to 12 months, and that works a bit better because physiology changes a lot in the first year. Now we've got electronic charting, which is good and bad because probably mainly good, but it's just changing the dynamic of the calling criteria because when the nurses chart the observations electronically, there's flags and reminders and prompts advising them what they really ought to do, and it's really hard to ignore a prompt when you might have ignored it otherwise and kind of nearly read or redo the observation when the patient's awake or not crying. That doesn't happen as much. We've seen coincident with this a marked increase in the number of calls we're receiving. But the really good thing about this is that it creates an audit trail and a data set at the back end of the EMR, which we can interrogate as and when we want to. So electronic charting has been rolled out the last couple of years, and it's pretty prevalent in New South Wales now. So the charts, but when we had the charts, we needed to launch the program between the flags, and to do that we had some awareness training and then some more specific training. So the first level of training is, hey, we're going to do things different, a bit like Felix was saying, there's all these people with grey hair saying, well, we don't have those charts, never seen them before, what's blue mean anyway? Incidentally, blue means increase the frequency of observations for the local nursing staff. We have a get out on all our charts. If someone's worried, just call. A bit like that wedge of patients that didn't hit the Victor criteria in Felix's presentation. We've got the same thing. You can just call if you don't like the look of somebody or you sense that you're concerned. And actually that's a very effective reason to call, we've discovered. First level of training was just be aware this is what it is, how we use it, this is what we expect from you, these are the behaviours attached to the colours, and this is how we roll around here now. Second level of training was, okay, well now I'm trying to assess what's going on, and I'm the first line responder, I'm one of the ward afferent limb responders. And how do I kind of attend to the problem while I'm waiting for someone to come? And the final level of training we've put in is around the responders. Detect Junior was a manual that we wrote with the CEC, and it described basically how we might go about assessing in a standard way what we thought was going on, and then starting emergency treatment while we were waiting for a team, and also gave us some ideas of how we might communicate with each other and some of the non-technical skills that we could utilise in terms of communication, teamwork, decision-making, understanding what's really going on with the patient. So I won't bore you too much with the detail of that, most of it's online. Just to say that Tier 2 training has got the manual underpinning it, but has got online e-learning, which we can see who's accessing and what their scores are and whether they hit a certain level of knowledge. And some face-to-face training, which is much more how do you do it, pass on the know-how on a day of training. And the participant feedback in the first 400 or so people that went through this was pretty positive, with these colours here indicating people that are quite happy. These people couldn't be bothered to tell us anything, wanted to go home. These were less happy, but they were okay. And these small wedge there thought it was useless. But on the whole, it was well received. People thought there was value in it, and it improved their confidence to conduct the appropriate skills and to spot and manage the situation that they may encounter in their day-to-day. So, training tick. Then, importantly, every CE in every local health district was asked to implement a clinical emergency response plan, and to oversight it, and to set up a committee to make sure that appropriate data was collected and reported to the CEC, and to look for continuous service improvement. And so governance occurs at a state level through the CEC, but also in every local area health facility, and also you're seeing from these presentations at unit levels. Each rapid response system to the red zone was defined locally, so they're not the same in every hospital, because the same people don't reside in every hospital and the same patients aren't in every hospital. So everybody had to define for themselves who ought to attend and what the reasonable timeframes were. There were some limits around that, and how that could work for them. There is a stated target, actually, and only by doing this talk did I realise this, and it's quite topical, because what dose is actually quite an important question. I saw Felix posed it, we discussed it earlier in one of the sessions with Ronaldo. So what is the right dose? But our target in the CEC is to have a rapid response dose of over 20 per 1,000 admissions as a benchmark. You'll see from the data I'm going to show you in a minute, we don't always get there. And we monitor the cardiopulmonary arrest rate. We do that across the state. So we've got a couple of things we've been reporting for some years, and we're starting to understand a bit better, and it leads us to the potential to start evaluating our data, which I'm going to try and do with you now. So these data from the CEC, so on the top graph there, you'll see that's going back to 2013, and goes all the way monthly to 2017. And you can see overall there's an increase in the rapid response rate per 1,000 admissions in New South Wales. This is all paediatric patients in the state. You can see also that there's some variation, and it looks pretty seasonal, but we haven't actually done a deep analysis, but that's our first impression of that. The graph below here also has rapid response rate per 1,000 on the top, which is increasing overall. And here's the cardiopulmonary arrest rate. It's never very high, but it's going down. So that's pleasing to see. So, hey, there's a temporal association. Those lines seem to be splitting. At least they're moving in the right direction. Can't imply causality, but that's promising. Well, let's have a little bit of a deeper dive into the data. Where are these paediatric patients, and where are these arresting patients? The first thing I thought I'd ask. So up here, in New South Wales, we categorise the patients, or the hospitals rather, where paediatric patients will be admitted by peer group, and there's A1, A2, B, C1, C2. A1 is a metro centre with probably with an adult ICU, a decent sized hospital facility without specific PICU. A2 are the hospitals with the PICUs. C1 is, B is getting smaller, C1 smaller, C2 very small, likely rural, limited facilities. You can see over here that the rapid response dose varies and has been, each bar represents 2014, 15, 16. So it's been going up and then flattened off a bit. Here at the children's hospitals, the teaching hospitals going up and then up a lot. Over here is plateaued. Over here is still going up in the C1 hospitals. And over here went up, went down, went up. So the pattern's very different. We're seeing quite marked variability in terms of how our system's been implemented. If we use rapid response dose as a marker of implementation or successful implementation, what we'd expect to see, what we thought we were going to see, was ongoing increasing dose, which has been the experience of many, until we plateau at a mature system. Now there's lots of reasons and there's lots of things in play, and I've mentioned some of them. When we think about where the arrests are, we're seeing that there's a kind of proportionate number of arrests there in the A1 hospitals. There's a disproportionately low number of arrests probably in the A2 hospitals, teaching hospitals with the big doses. There's a decent number of arrests there in the B hospitals, quite a lot actually in the small number of patients in the C1 hospitals, and then a small number in the smaller hospitals as well. So they're happening everywhere, which is important, and they seem to mirror a little bit what's happening in terms of dose. I'll look into that a little bit more in a minute, but I just want to break those hospital groups down a little bit more. So you can see that these are just the A1 hospitals. These are not the hospitals like the one I work at, but these are metro hospitals with a lot of people around and usually a lot of expertise in the adult services. You can see their dose is going up. It's plateaued a little bit, and their arrest rates are going down overall, though there's variability again. So that looks promising, and a bit like that first graph I showed you. When we start looking at the other groups here, I'll show you A2, which is the children's hospitals, B and C1. You start to see slightly different things. So here's a graph of the dose here and the arrests. Bouncing around, these are the A2 hospitals, and we're hitting whole times we have nothing, and then we seem to have these crazy outlier months where we get a lot of arrests. So it's not entirely clear why that's happening. If you put a line of best fit, I'm not sure you should do that, but someone has. It seems to be going down a bit, encouraging, but not definitely getting better. Again here, these are the B hospitals. Their dose has overall increased, although it did dip down there, and their arrests are mainly going down. They've had substantial periods now where they didn't seem to get them without any arrests, which is good. And then the C hospitals, the smaller hospitals, their dose is going up, and they hit whole weeks and months of no arrests now, whereas they used to get them scattered around all the time. So I think the data seems to be different, but has different patterns in different types of institutions. Again, these are clusters of institutions, and individually within group variation is going to be marked probably, and we haven't been able to look at that yet. If you were to plot the cardiopulmonary arrest rate per 1,000 admissions against the dose in the group of hospitals you're looking at, and you did that by the different groupings I've just showed you, you get this curve. So this is the crazy outlier massive dose hospitals. They're the children's hospitals. They have the lower arrest rate per number of admissions they have. And then up here, the lower dosing hospitals of different types of facility have the highest arrest rates. I think that's interesting. There's probably room to improve the dosing, the rapid response dose here, and you'd hope that we can drag these dots down somewhere down here. We'll see. So, does mandatory calling work? Well, I think most of us here think it works, but probably yes then. But only if you implement as part of a system of changes with really good local governance. But it doesn't work everywhere, it doesn't always work, and it doesn't work in exactly the same way. and that's the tricky bit. So this is the Children's Hospital Westmead. It's just to illustrate that point. This is a paper I like, and I've read a few times now, from Cafazzo, which talks about the hierarchy of intervention effectiveness. More effective going up that way, less effective down towards the bottom of the slide. And you see things like forcing functions, computerization, automation, simplification of process, reminders, checklists, rules, policies, and education at the bottom. See here mandatory calling, it's important, it's a forcing function. It's probably it's a big reason probably why we're getting the improvements we think we're seeing. Over here, the EMR is important. Other things like alerts, reminders, and we use automated watch lists that are generated at times of handover. The Spock charts are standardized. We have a certain way of responding. It's the same people, they behave the same way, and they invite responses. They use the same language. We have team talk and patient safety pauses now. That's all grown up at the same time as we've implemented MET. We have watcher lists and parent-activated rapid response. And yeah, we do some education. But when we do the education, it's in the context of what I've just said and the systems we're using. So that's how we go about doing our system. Everywhere is going to do it differently depending on their own needs, their own patient population, the kinds of problems they would have, and importantly the resources available to attend these patients should they be deteriorating. So it's a complex system. I think the key is that we monitor, we try and understand and continuously try and improve it. And I think there are a number of future challenges that I hope we get to talk about in the next couple of days. What is the right dose? We're all asking the same question. And what about this variation that we can see on these graphs? There's different types of variation. There's stable system variation, which we could define around 3 sigma or 99% confidence intervals, versus special cause variation, which are those crazy spikes. Why are they happening? We don't know. We need to understand that, monitor our systems, make changes, measure, monitor, change, monitor, and basically we need to evolve. And that's the talk. Thanks to everyone at the CEC.